So, well, good morning, good afternoon, good evening, wherever you are. I know it's evening for a lot of people. Thank you for joining me this morning or this time. This is going to be topic 6 of the course in Gynecological Brachytherapy Physics. So we're going to be covering applicators and their uses. So before I get started, I guess let me go back a second. I didn't introduce myself. I'm Dan Scanderbeg. I'm with UC San Diego. And so my next slide here show you a little bit of where I am in the world in relation to everybody else. So I'm in the United States, down in this little corner here in Southern California. So on the right, we have a little blow up down here. And so a little bit about me, and the next 2 lectures are going to be from a colleague of mine that's also here, Derek Brown. And then the week after that, I have another lecture. So I thought I'd tell you a little bit about our sites. So I am stationed here at our main site. We have 2 buildings at our main site, and then we have a variety of satellites. Like I said, here at our main site, we have 2 facilities. We have 4 linear accelerators, 1 HDR suite across the 2 clinics. At our clinics here, we have 4 Varian linear accelerators, all with onboard imaging. So we have 2 TrueBeams, a Halcyon, and a 21EX. We use all Varian ARIA, Eclipse treatment planning, Brachyvision. We have 2 CT simulators, a GE large bore, 16 slice, and a PET CT, both with 4D capabilities. So for brachytherapy, we have 1 Varian HDR remote afterloader. It's a Verisource. We also do Veriseed for our LDR planning. So we do prostate seed implants. And we have a BK Medical Flex Focus ultrasound system. And I'll talk a little bit about that in the talk as well, because we do use that for HDR planning. So some of the disease sites we treat. So we have experience treating HDR for gynecological, breast, prostate, endobronchial treatments, sarcomas, and we've also done HDR brain treatments. For LDR, we do prostate and ocular melanomas, and then some other sites in the body. We've done some mesh implants for like retroperitoneal areas, things like that. Okay, so that was just a little bit about me and what we do here, so you have an idea. So this is an outline of the presentation on topic 6, brachytherapy applicators and their uses, with a focus on gynecological brachytherapy. So we're going to start with a brief description of anatomy associated with gynecological procedures, which will hopefully help us understand how the different applicators work in the various areas. So after looking at anatomy, we'll move on to a little history of gynecological brachytherapy treatments, some historical definitions of important points or structures. Once we have finished that, we'll move on to applicators, including descriptions and pros and cons of each of them. And then following this introduction, we'll look at loading schemes used for each. So one of the key advantages of brachytherapy is the application of creativity in implanting for a patient. So we'll discuss some points regarding the importance of creativity at the end. And then we'll look at a clinical overview of the entire process and then a short introduction of titanium versus plastic applicators. However, this is just going to be a short intro, as there will be more in-depth discussion later on for those who have MRI available in their clinics. So here's a basic diagram of common anatomy and terminology that we should all be familiar with for gynecological procedures. In the lower part of the diagram, we can see the vagina. As we move superior, we come to the external cervical os, or the opening of the cervix into the vagina. Next, as we continue to move superior, we pass through the cervix and internal cervical os and into the uterus. As we keep moving superior, we come to the fundus of the uterus, and then if we move in either direction laterally, we'll hit the fallopian tubes and then the ovaries. The uterus can be divided into 4 major regions. There's the fundus, or the uppermost rounded part of the uterus, the body or corpus of the uterus, the cervix, and then the cervical canal. The uterus can be further subdivided into the endometrium, which is just the lining of the uterine cavity, and then the rest, or the majority of the uterus, is the myometrium, which is just smooth muscle. It's important to note the features of the anatomy in order to understand the applicators that can be used to treat different regions. The vagina is an elastic muscular cavity that starts at the vulva and then extends to the cervix. At the apex of the vagina, closest to the cervix, are the vaginal fornices. The fornices can be divided into 4 regions. They are the anterior, posterior, right lateral, and left lateral fornices. The posterior fornix is deeper than the anterior fornix. Understanding of this anatomy is important when we describe applicators, such as the vaginal cylinder. So the cylinder is used to treat a length of vagina. Since the vagina is elastic muscle, we want to choose the cylinder that is the largest diameter, that's not unreasonably uncomfortable for the patient. This ensures that there are not air gaps between the vaginal mucosa and the cylinder that could lead to uncertainty in dosimetry. Additionally, the vaginal fornices are important for cervical cancer treatment, as the ovoids or the ring should sit in the vaginal fornices area and up against the cervix. The cervix is the lower part of the uterus and is generally about 2 to 3 centimeters long. The cervical canal is a narrow canal that runs along the entire length of the cervix. It's a narrow opening and needs to be dilated to accommodate the tandem inserted for cervical cancer treatments. The tandem will run the entire length of the uterus from the cervix to the fundus. It's important to note that the uterus is also a muscle and that the tandem can be sharp enough to puncture the fundus if enough pressure is applied during the insertion. So it's important to note the position of the end of the tandem in relation to the fundus. Care must be taken to not load a tandem that has perforated the uterus. Again, I mentioned the dilation. So it's important to look at the type of applicator that you're going to be using and look at the different tandem options. So some of the tandems will have a much narrower diameter and some larger. And so that will lead to more dilation being needed if it's a larger diameter. So those are all things to consider when starting your program. This is a sagittal cartoon of the pelvic anatomy in order to better visualize the normal structures surrounding the vagina and uterus. As you can see in the diagram, the bladder sits anterior to the vagina and the uterus, while the rectum sits posterior to the vagina and the uterus. The rectum turns into the sigmoid at the recto-sigmoid junction as you move superior in the patient. And then with these structures adjacent to the treatment areas, we need to be careful to monitor dose to the normal tissue, as well as the effects that bladder and the rectal filling can have on the anatomy and your implant geometry. Of note are additional man-made features that might be encountered in the patient anatomy. One example is the Foley catheter and balloon. So a Foley catheter, it's a small sterile tube that's inserted through the urethra and into the bladder to drain urine, and it can be left in place for a short time. The catheter has 2 ports. One is open at both ends such that it can drain the urine from the bladder into a collection bag, and the other port runs to a balloon that can be inflated with sterile water inside the bladder so that the catheter doesn't slip out. For gynecological brachytherapy procedures, the Foley will often be used and the balloon will be filled with contrast so that it can be visualized on CT or radiograph. The picture on the left of this slide shows the balloon sitting in the bladder and filled with contrast. The balloon is also used for definition of the ICRU bladder point, shown in the picture on the right, and I'll discuss that a little bit later in the presentation. Another example of man-made feature that might be encountered in the presence, is the presence of rectal contrast or contrast-impregnated packing. So much like the insertion of the Foley catheter, a small catheter can be placed in the rectum and contrast injected prior to imaging to help with visualization of the rectum. Likewise, packing in the vagina to hold the implant in place and increase the distance between the implant and the rectum can be impregnated with contrast to help visualize the posterior vaginal wall. However, it's important when using the contrast to be careful not to create artifact in the scan that prevents visualization of the applicators or the source paths. So now that we've seen some of the advantages of brachytherapy, let's look at a very brief history of gynecological brachytherapy. So as many of us know, brachy is from the Greek word brachus, meaning short, in this case, short distance therapy. It was developed soon after Henry Becquerel discovered radioactivity in 1896. Pierre Curie and Henry Alexander Danlos, they discussed the use of a radioactive source inserted into a tumor all the way back in 1901. Pretty incredible. It was then found that this caused the tumor to shrink, and hence radioactive sources were continued to be used for the treatment of cancerous malignancies. Alexander Graham Bell, interestingly enough, was also said to have suggested the use of radiation in this manner to treat tumors. So radium was the isotope used in the early treatment of cancer in the late 1800s and early 1900s. And then in the following decades, radioactive radon gas was separated from the decaying radium and then encapsulated in glass tubes, which were then used for cancer treatment. It was also during this time that encapsulation techniques emerged that allowed for filtering of beta particles from the radioisotopes, and it thus prevented high doses and tissue necrosis very close to the sources. Initially, radium needles were also used as they were directly implanted into a patient. A radium needle is shown on the left, and then the two pictures on the right show two very early applicators that maybe if you squint, use a little bit of imagination, they look closely resemble our current tandem and ovoid type applicators. So from 1920 to 1950, there was a lot of experimentation with the use of radium and radon for treatment of cancer, and a tremendous amount of clinical data was obtained. So many of the modern techniques used today were developed during this period and have been slightly modified over the years with technical evolution. In the picture on the right, we can see the evolution of some of those early applicators. In 1953, the physician Fletcher introduced preloaded radium applicators. Then in the 1960s, these were modified for afterloading, minimizing exposure to the staph. In the 70s, the applicators were modified again for use with the isotope cesium-137, and then finally modified for use with our modern high-dose rate afterloaders using iridium-192 or cobalt-60. These two radiographs show an applicator inserted in a patient. On the left is an anterior-posterior or AP radiograph showing the placement of a tandem and ovoid applicator. You can actually see the loading pattern kind of scribbled on the right-hand side. And then on the right side of the slide, the other picture is the lateral radiograph from the implant. So the Foley balloon and the bladder can be seen anterior to the applicator. Historically, there were three primary approaches for interstitial implants that were developed for radium implants and used for determining the distribution of activity for these implants. Now, with our sophisticated treatment planning systems that rely on computer calculations, these systems are pretty antiquated. However, it's good to know the general principles from these systems, as a lot of our modern techniques have evolved from these older principles, and they still do apply for all kinds of brachytherapy treatments. So the three systems are the Quimby, the Manchester, and the Paris. The Quimby system was named after Edith Quimby. She was a physicist at Columbia University. This implant system used one or more planes of implant that contained a uniform distribution of sealed sources. So because it was a uniform distribution of sources, it produced a non-uniform distribution of dose to the treatment area, as the dose to the central region was much higher than at the periphery. The Manchester system, also known as the Patterson-Parker system, is named after its creators, Patterson and Parker, and their location in Manchester, England. In this system, they used a non-uniform arrangement of sources in order to achieve a more uniform dose distribution across the treated area. The Paris system is similar to Manchester, but does not allow crossing of sources. So it includes longer sources at either end of the implant in order to compensate for uncrossed ends. In the 60s came the Fletcher system, and that kind of combined the elements of the Paris and Manchester system. In addition to anatomy, we should know some key definitions. The following slides show diagrams of the physical locations of these points and the definitions after I verbally describe them here. So we often hear about a prescription dose or prescribed dose to point A. So what is point A? Where is it? What does this mean? So the general description of the location of point A is that it's physically located 2 centimeters superior to the external cervical os, and it's 2 centimeters lateral to the cervical canal. This was originally defined in the Manchester system of implants that we just talked about, and is continued on to this day as the prescription point or normalization point for cervical cancer implants. This geometrical point, it's supposed to represent the location where the uterine vessels cross the ureters, and it's the tolerance of this area that was thought to be the dose-limiting factor in radiation therapy for the cervix-uterus complex. Now with 3D imaging, we can better visualize patient anatomy, but with decades of clinical data behind us, we still use point A as our prescription point, and then adjust depending on individual anatomy and our DBH metrics. I'll describe the exact way of finding point A on the next slide, as presented by the American Brachytherapy Society. Point B, it's often tracked as well for dose reporting. So it's located 2 centimeters superior to the external cervical os, same as point A, but this time it's 5 centimeters lateral to the patient's midline. So this point represents the dose to the patient's pelvic sidewall. So this is independent of the tandem, independent of the implant geometry. And again, I'll show that in a second. In 1985, the International Commission on Radiation Units and Measurements, or ICRU, the report number 38 was published, and it defined several reference points for dose reporting. The point dose for the bladder is calculated by placing a Foley balloon in the bladder filled with 7 cubic centimeters of contrast, 7 cc's. And then on the AP radiograph, the bladder point is marked at the center of the balloon. On the lateral radiograph, the bladder point is marked at the posterior surface of the balloon, where a line is drawn through the center of the balloon, where it would fall. The rectal point is defined as the midpoint of the ovoids on the AP radiograph, and then on the lateral radiograph, 5 millimeters posterior to the vaginal wall on a line drawn down the middle of the ovoids. So I'll show this pictorially in the upcoming slide. So here is the generic diagram of point A on the left. Again, it's physically located 2 centimeters superior to the external cervical os and 2 centimeters lateral to the tandem applicator. Point B is an additional 3 centimeters lateral, so 2 cm sup and 5 cm lateral. This description is from the original Manchester system of implants. More recent recommendations of identifying point A come from the American Brachytherapy Society and state that one should connect a line through the center of each of the ovoids or the lateral most dwell position in a ring. From the point on the tandem where this line intersects, extend superiorly the radius of the ovoids or ring, and then move 2 cm along the tandem. Point A is then 2 centimeters on either side laterally on a perpendicular line from the tandem. So this is shown in the middle diagram. The diagram on the right shows how to define point A for a tandem and cylinder treatment. So if you don't have the ovoids or the ring, just a tandem and cylinder. So for a tandem and cylinder, start at the flange or the top of the cylinder, or seeds that mark the cervical os, and then move 2 centimeters superior along the tandem and 2 centimeters lateral. This is another diagram displaying points A and B when the implant isn't in line with the patient's midline. So here it demonstrates that point A is lateral to the applicator, while point B is lateral to the midline of the patient. So here we can see 2 centimeters superior and lateral in the plane of the tandem for point A, but here 2 centimeters superior and then 5 cm lateral to the patient's midline for point B. This sagittal diagram shows the bladder and rectal dose points. You can see the Foley balloon at the top of the screen. The bladder point is marked at the posterior surface of the balloon, where a line is drawn through the center of the balloon would fall. The rectal point is defined 5 millimeters posterior to the posterior vaginal wall, directly posterior to the center of the ovoids or the ring. One should place the rectal reference point on the axial CT slice at this location. Okay, so now we're going to move on to the applicators, the different applicators and the pros and cons. So this might be a nice place to stop for just a sec to see if there are any questions or give people a break. Okay. I guess everything's clear as mud. Okay, so if you have any questions, feel free to put them in the chat, and I'll keep going for now, and we can come to them as they come up. So let's take a look at some of the various types of applicators that we can use for gynecological brachytherapy. Probably the simplest and most common applicator is the vaginal cylinder. So the vaginal cylinder is composed of a central lumen for the source, and then it's surrounded by either a solid cylindrical applicator or a segmented cylinder that can be stacked to form a specific length. The left-hand picture here shows a cylinder from Electa, Nucleotron, and on the right is one from Varian. Both have similar components, as mentioned previously, with the central lumen for the source to travel, and then segments in various diameters that can be stacked together to set length. So typical segment diameters or applicator diameters range from about 2 cm to 3.5 cm in 5 millimeter or 0.5 cm increments. The cylinder, it's a simple design with the central lumen for the source, and so the dosimetry is fairly straightforward as well. We know that a single dwell position will have a fairly spherical dose distribution, aside from the little bit of anisotropy. This is true for the dosimetry of the cylinder. So as you add more dwell positions and have a longer treatment length, then the isodose distribution creates a cylindrical shape, mimicking the applicator shape. Typical prescriptions for the cylinder will be for the prescription dose at the surface of the cylinder or at a 5 millimeter depth from the surface of the cylinder. It's also important to have proper communication with the physician as to the treatment length. So one way to specify this is to use an active length, where the active length means the total length of the active dwell positions in the cylinder. So for example, if we have a physician that states they would like 3 centimeters of active length, and we use 5 millimeter source spacing then that would mean we would have 6 active dwell positions for this treatment. Because we have 6 dwell positions at 5 millimeters each, 6 times 5, we have 3 centimeters total. So when starting a program, it's crucial to discuss how the physicians want to prescribe the dose for a cylinder treatment and that they understand what it means dosimetrically. Another planning scheme is to use the planning length aim, which is defined as the length of the vagina treated with the planning aim dose. So I believe that's how Adam and the program is teaching for the planning aim dose. But it's very critical to get that idea conveyed to the physician and the team so that everyone's on the same page and the planning is very consistent. So loading of a cylinder will be covered in another section. I think Derek is doing that next week. But in general, we'll start with loading at the most distal position and then however many dwell positions are needed to cover the planning aim length. In order to get a uniform dose across the surface we're attempting to treat, dwell times are generally higher at the tip and the tail of the loading and relatively shorter in the middle dwell positions. If we had uniform dwell positions, then we would not have a very uniform dose distribution. We kind of bulge out at the center in the middle with higher dose. In the previous slide, I mentioned that the cylinder is one of the simplest designs for an applicator. However, there are a few variations of the cylinder that are more complicated and can be used for specific situations. So one example is the multi-channel cylinder that many people refer to as the Miami cylinder. This applicator, it has many lumens near the surface of the applicator and they surround the central lumen. So this allows for a little bit more dose sculpting to enhance or reduce dose to certain areas. However, since there isn't a lot of separation between the central lumen and the peripheral ones, I say you kind of nudge dose or only shift it subtly in a certain direction, not huge. So here you can kind of see the central lumen with the surrounding peripheral ones. So you can kind of shift the dose a little bit to different areas. So if you're very close to the rectum, you could shift dose away from that. Another example that can be used to greatly shift the dose distribution is a shielded cylinder. So inside this applicator are shields that usually come in quarter circle angles, 90 degrees, 180 degrees, or 270 degrees. So for example, if you used a 180 degree shield and placed it posterior, then you would effectively shield the posterior vaginal surface and the rectum while giving dose to the anterior vagina and beyond. The picture on the left, again, shows the Miami applicator, and then the picture on the right shows the shielded applicator with its various shields and segments and how they all come together. So these shields just insert into your cylinder along with your central lumen. Shown on this slide is a picture of a cylinder with an intrauterine tandem. So the cylinder is placed in the vagina as with a regular cylinder, but the intrauterine tandem can be placed up into the uterus to treat parts of the uterus. So this applicator, it combines the dosimetry of a tandem with that of a cylinder and allows coverage of the uterus and then all the way down into the vagina. So what are some of the advantages and disadvantages of cylinders? They have a very simple geometry that I think is both an advantage and it's also a disadvantage. So it's simple geometry, so you can do an easy dose calculation. You can even have standard loading plans. For example, you can have a 3 centimeter diameter cylinder plan with a standard prescription to a set depth and for a set length. And as long as the cylinder is reproducibly placed in the patient, then it's going to deliver the plan. However, with simple geometry and with the single source lumen, it also leads to a lack of flexibility in the dose distribution. So you're kind of stuck with your cylindrical symmetry. What you see is what you get. And that's where the modified cylinders come into play, such as the Miami or multi-channel cylinder or shielded cylinders or other cylindrical applicators if you want to get more more complicated and shape the dose. Okay, so next I will talk about interstitial needles, since they can be used for almost any treatment site as long as the physician can place them appropriately in or around the target area. So interstitial needles were the first applicators used, and it's also important to know of interstitial needles because we'll introduce hybrid applicators, which combine the intracavitary components with interstitial components for improved dosimetry. On this page is a picture of stainless steel needles from Varian, those are the ones on the left, and from Electa on the right. Interstitial needles, they offer flexibility and good dosimetry as long as the needles are placed appropriately. So if they're placed appropriately, then the dose can be sculpted to conform to the target very well and reduce dose to the adjacent organs at risk. An interstitial implant takes advantage of the inverse square law with your source positions in and around the target area, closer to the target than the organs at risk, thus allowing for a really high conformal dose to the target while letting the dose fall off outside the target as you move towards the periphery and the organs at risk. So really with a well-designed and implanted interstitial implant, you can have the most conformal radiation dose or radiation treatment possible with less dose to surrounding tissues and no entry and exit dose like in external beam, because the source is irradiating the target from the inside out. As I mentioned before, there's going to be a special section on applicators or needles that can be used with MRI and how those work and how to commission them and all that good stuff. So I just wanted to introduce what those needles are. So some MR compatible needles come either in titanium or plastic. As you can see in the picture on the left, the titanium needles look very similar to the stainless steel needles on the previous page. And then on the right are some plastic needles. The metal needles are much more rigid and can be more easily guided into place than the flexible needles. However, many metal needles close together can lead to a lot of artifact on CT and make it more difficult to visualize the soft tissue around the implanted area. Additionally, needles can also have blunt tips or sharp tips. So one of the advantages of having a blunt, flexible needle is to reduce the chance of a vessel puncture. So those are all things to think about as you again, start a program or start treating new sites or introduce new techniques. So these are a few advantages and disadvantages to the interstitial needles. Advantages include terrific dosimetry, and they can be used almost anywhere as long as the physician can place them, and they can be fixed to that location for treatment. That's another important point, so that they stay in position. Interstitial needles are good when the extent of the tumor can't be encompassed by a standard intracavitary applicator, or when there's a narrow vagina that doesn't allow the use of appropriate vaginal applicators. They can also be used with patients with prior hysterectomy that prevents tandem placement, and for patients with recurrences inside an area that was previously irradiated and prevents further use of external beam radiotherapy. Additionally, they're relatively straightforward to plan with good implant geometry that I will discuss in a second. As long as the interstitial needles cover the target area with proper spacing, then you'll be able to achieve good dosimetry, much, much better than with other applicators, since you have many variables, the needles, that can be used to cover the target area and spare the normal tissues. However, if the needles are not placed with adequate coverage and spacing, then it will be impossible to achieve your planning objectives. Key disadvantage is that they're extremely labor intensive for both the physician and the physicist, and they require a high level of technical skill because of the nuances. So many physicians have not received a lot of training during residency in interstitial implants, especially here in the US. So putting needles into tissue requires a high level of competence by the attending physicians, and even a high level of confidence and skill. The process, it can still be quite labor intensive. This is the same for physics in order to correctly connect, measure, label, digitize each of those needles. However, with good placement, as I said, particularly if a template is used, that helps tremendously over freehand. It's often much more straightforward to digitize each needle. So if the implant has many needles that are difficult to identify, then the process can be very, very time consuming and much more difficult. Key point with interstitial implants is to start with good implant geometry. So again, I'm emphasizing it because if you don't have adequate placement of the needles, it's going to be impossible to get a good plan. If you have good needle placement, then you'll be able to adjust your dwell times in each needle to come up with a great plan that's going to meet your planning aims. The picture shown on the left is an Electa, Tandem, and ovoid set. So while the figure on the right is a barium, Tandem, and ovoid set. So the Tandem and ovoid, it consists of an intrauterine tandem of varying length chosen by the user, as well as varying angle, so also chosen by the user. There can be a cervical stop that's placed on the tandem and tightened down to prevent the tandem from moving superior farther into the uterus, and it also makes for easy identification of the external cervical os. Additionally, there are two ovoid lumens, one for the right side of the patient, one for the left side of the patient. There are typically 4 sizes of caps that can be placed onto the ovoids. These are minis, small, medium, and then large caps. So dosimetry for a tandem and ovoid set looks kind of like a pear, shown on the left. So it's often described as having a pear-like dose distribution in the AP image. So the dose distribution from an implant is shown on the right of the slide, and then you can compare the similarities between the two. The section near the external os in the vagina has a wider dose distributions with contributions from the ovoids, while the dose narrows as it goes superior in the patient and is receiving most dose from the intrauterine tandem. This shape conforms to the usual growth of cervical cancer, as it typically spreads from the cervix superior into the uterus and then also laterally into the perimetrium, thus pear-shaped, looking at it in that coronal view. The choice between using a tandem and ovoid kit and a tandem and ring kit is mainly based on physician preference. There are also some advantages and disadvantages to using the tandem and ovoid kit. So one of the advantages is the flexible geometry of the kit. With multiple size ovoid caps and tandem lengths, it's possible to fit almost any patient, and the tandem and each ovoid is independent of each other. So it's very flexible how it all fits together. However, it does require a bit more technical skill from the physician to implant these correctly in the patient, making sure that the ovoids don't drop down into the vagina and they stay secure in the vaginal fornices. Additionally, because the geometry is not fixed and can change with each implant, it's necessary to have a pre-treatment scan and a new brachytherapy plan for each implant. Also, the larger ovoids, they can be loaded significantly more than a ring applicator and thus treat to a deeper depth while treating the same dose to the mucosal surface that touches the applicator. This can be particularly useful for larger tumors. Okay. Tandem and ring. So the next applicator kit is the tandem and ring. Although there are metal versions available, I've displayed on this page 2 plastic versions, one by Electa on the left and another by Varian on the right. Both models have a central intrauterine tandem that passes through the ring. The ring mimics the ovoids in that it's placed up against the external cervical os in the vaginal fornices. But with the ring, you have more options for source dwell positions that I'll explain on the next slide about dosimetry. The applicator on the left has one additional piece not shown on the right picture, and that's the rectal retractor. Let's see if I can highlight it down here. So this piece, it looks like a small paddle that's on the posterior side of the applicator. So when inserted, it can be angled down from the outside, and it pushes down on the posterior vaginal wall and increases the space between the applicator and the rectum. So increasing the space, we're taking advantage of our inverse square law. So it increases the space and then helps decrease the rectal dose. This slide shows the dosimetry from a tandem and ring applicator. It's very similar to that of the tandem and ovoid applicator kit, since it's essentially the same geometry. The picture on the right shows a 3D image of the applicator and some normal structures. The intrauterine tandem passes through the center of the ring. Bladder is located anterior to the applicator and rectum in the posterior. You can also see the rectal retractor is colored blue in this picture and is located between the applicator and the rectum. So here are our tandem, our ring, our bladder, rectum, and then the rectal retractor pushing that rectum away from our applicator. Some of the advantages of a tandem and ring kit are that it can lead to better placement among patients with a narrowed proximal vagina or loss of vaginal fornices. The ring also offers 360-degree capability of loading, or nearly 360 degrees of loading source dwell positions that can be beneficial in some cases to accommodate the spread of disease in the vagina. The tandem and ring applicator, it's fixed geometry, so it can have a standard or template plans. However, the fixed geometry can also be a disadvantage since it can't be adapted to all patient anatomies, and it can be difficult to use or place in some patients. Another disadvantage is the opposite of the advantage of the large ovoids that we just talked about a second ago. So we said earlier that the large ovoids could be loaded greater than a ring to treat large tumors with similar dose at the mucosal surface. So here with a ring, it's a disadvantage that it can't be loaded as heavily to treat those larger tumors. So if you had the large tumor and you wanted to get a high dose in that area, you'd be better with your large ovoids to reduce the vaginal mucosal dose. Okay, hybrid applicators. So now that we've been introduced to interstitial needles and implants, along with our intracavitary applicators, we can look at hybrid applicators. So they're appropriately named as they combine the intracavitary and interstitial techniques to improve dosimetry with increased target coverage and lower organ at risk dose. But they're not quite as complicated as full interstitial implants. So on this slide, we can see an Electa applicator on the left that's a tandem and ring applicator with holes for needles that pass through the ring, and it also has additional attachment proximal to the ring that guides those additional peripheral needles. On the right is a variant applicator that's also a tandem and ring with needle holes in the ring, usually referred to as like a Vienna style ring for supplementation applicators, so adding needles to extend that dose lateral to the ring. The dosimetry, again, it's very similar to a traditional tandem and ovoid or tandem and ring applicator in that we're still trying to get a pear-shaped dose distribution with our starting point of prescription at point A. However, the additional needles can help to get more dose to the target, which can often extend laterally at the cervix, and yet we want to keep the dose to the organs at risk within tolerance since we're using the inverse square law to our advantage. And placing those needles and dwell positions in and around the target further away from the OARs. So this allows for a more sculpted dose to the target than with just a traditional intracavitary applicator. The pictures on this slide show the traditional intracavitary implant on the left, followed by a hybrid applicator in the middle with parallel needles. So the needles are just parallel to the tandem, and improved lateral coverage, and followed by a hybrid applicator with both parallel and oblique needles in the third picture from the left. So this one here, it adds even more lateral coverage as you have those parallel and then the oblique going way off to the side. As mentioned on the previous slides describing hybrid applicators, the advantages are they combine the dosimetric aspects from intracavitary and interstitial implants. So thus you can improve dosimetry over your traditional intracavitary implants. With this improved dosimetry, we do see survival benefits for patients in the range of 20 to 30% in locally advanced tumors when compared with conventional brachytherapy. It's technically easier for the physician and physicist over a full interstitial implant. However, it is still complicated and technically more challenging than just a straight intracavitary implants, because you are inserting a few needles. So loading patterns, there are a variety of methods to load a given applicator, and we'll focus on the one given in your handouts and what they've been teaching. So, and I think what Derek will go over in cylinders next week, and tandem and ovoids, and then what I'll follow up the following week with tandem and ring. So in the scheme, all applicators will use a 3 millimeter step size for Varian gamma med afterloaders and a 2.5 millimeter step size for nucleotron afterloaders. When loading the tandem, we just want to load dwell positions to the outer surface of the ovoids or the ring, not beyond them, such that the sources are protruding into the ovoids or ring or even further into the vagina. So we don't want to do that. So we want to load according to the plan on this slide, and this is the handout that's available to you. So I'm going to go just briefly through it since, again, we'll talk about it in the future presentations, specifically talking about cylinders, TNOs, and TNRs. So for the tandem, when we have a tandem length of 6 cm or greater, we'll start with 15 seconds for all dwell positions in the distal third of the tandem, then 10 seconds for the remaining 2/3 of the tandem. For a 4 cm length, we'll load the distal half with active dwell positions of 15 seconds and then half at 10. And then if the tandem is really short, about 2 centimeters, then all dwell positions will have 15-second dwell time. These will later be normalized to the reference point. For the ring, we'll load all active dwell positions with 7.5 seconds, and these will be symmetric about point A. So for a 34 millimeter nucleotron ring, we'll load 8 dwell positions on either side. For a 30 millimeter nucleotron ring, we'll load 7 positions on either side. For a 26 millimeter nucleotron ring, 6. And then for the 30 millimeter Varian ring, 6 dwell positions on either side. And the 26 millimeter Varian ring, 5 positions on each side. So again, I'm going quickly. This slide, this handout is available to you. And later on, whoever will be working with your site will go over the specifics from the equipment that you have. For the ovoids, it's not in this handout. I think that still needs to be updated for you. Traditionally, we mimic the active lengths of traditional cesium sources. So most report using mini ovoids with 1.6 cm active length, smalls 2 cm, medium 2.5 cm, and large 3 cm. Again, you'll get that information in your handouts. And then finally, for cylinder treatments using the gamma med system, instructions are also shown here, which I think Derek is going to cover next week, talking about cylinders. Okay, so that takes us to the end of applicators. Let's see. I only have a few slides left. I see one question that came in. Are you using a 5 millimeter step size? Personally, yes, on our Varian Verisource afterloader, we are using a 5mm step size increment. Although I think the Atom, as I showed on the previous, I think I had it on the slide. Maybe I cut it off, but I believe it's in the handout. I think Adam has a specific step size he once used for the Gamma Med and the Electa. But yes, personally here, I am using a 5mm step size. Okay, so I do want to mention creativity in brachytherapy. So I think it's really important to talk about creativity. There's so many more variables in brachytherapy compared to external beam radiotherapy. And it's important to remember those options and not kind of get stuck with very rigid thinking. We want to think outside the box. Treatment options don't have to be limited, especially with evolving technology. So on this slide, I'm showing a variety of treatments using a lot of common equipment. So on the top left, we see some superficial skin treatments using bolus or thermoplastics that can be molded to a patient's skin surface, and then embedded or affixed catheters for the source to treat the target area or areas. The top right, it shows a thermoplastic hand mold. So this was a sarcoma patient that was treated on their hand. The bottom left shows an open implant for a sarcoma patient treated with an interstitial implant. The bottom picture, the second from the left, shows a patient with a basal cancer of the lip that was treated just with 3 interstitial needles across that lower lip. And then the 2 pictures on the bottom right show a 3D printed mold and a model of what it looks like with source paths. So it's important to remember that we have a lot of tools at our disposal, and we can use our ingenuity to come up with unique treatment options for unique patients with their own anatomy. So every patient is a little different. We should think a little differently about each one and try to offer the best treatment option for them. So we'll just finish up with a quick summary of the clinical workflow for gynecological HDR treatment, including the processes involved. So the next slide shows an example of a chart diagram of the processes involved in an HDR brachytherapy treatment. So basic flow for a typical implant would start with the patient coming in the day of the procedure. All medical conditions would be checked to ensure safety of the implant. The physician would then choose the implant and begin the procedure. Once the applicator or applicators are inserted, then the patient would move to imaging. Once images have been acquired, then the treatment planning would begin. After treatment planning, including the contours and digitization or reconstruction of the applicators, the plan would be checked by the physician and physicist before beginning treatment. After the treatment concludes, the applicator would be removed from the patient and they would eventually be discharged. The flow chart here, it's just a very broad overview. It's more generic for all HDR procedures. It includes multiple steps and processes, starting with the physician seeing the patient in consult. It then branches to various steps like pre-treatment, patient implant, patient imaging, treatment planning, treatment plan approval, etc. It also has several steps or processes associated with each of the aforementioned steps. So why is it important to look at a treatment procedure from a process viewpoint? The short answer is that it can help us to improve the safety in the clinic and for a patient. So it's really important when starting a program to think about the overall process and processes involved in each procedure, as well as the roles and responsibilities of the individuals involved with that patient's treatment. So this should lead to a critical analysis of the processes involved and areas that can lead to failure modes. So failure mode analysis can help to mitigate problems before they become actual clinical problems. So one example of a potential hazard that could be mitigated with appropriate safety barriers. So this is a picture of a patient connected for a 20-channel interstitial GYN procedure. Actually, it was more than 20 channels, but the afterloader only had 20 channels, so it had to be reconnected halfway through. As you can see in the picture, there are a lot of transfer guide tubes, plus a lot of needles in a very, very small space. So since the transfer guide tubes for this particular vendor, applicator, afterloader, they can be connected to any needles. So these aren't keyed in any way. So, channel 1 could be connected to needle 14 and, vice versa, all over the place. So it's definitely a place to look at implementing safety barriers to ensure your proper connections. This is just one example of what to look for when starting a program. There should be some thought experiments on what's likely to occur, even what's unlikely to occur, but still there's a possibility, and how those events can be mitigated if they could potentially lead to patient harm. Although most would look at this and say it's not nearly as complicated as the implant depicted on the previous slide, there's still a huge potential for mistake shown here. So this is just your simple tandem and ring applicator with 2 connections coming out of the patient, with the tandem being more posterior and the ring more anterior. However, if you're unsure on which applicator is which, you just have a 50% chance of connecting it correctly. And you'll get a wildly different dose distribution and medical error if you swap them and treat incorrectly. So with a lot of needles, that kind of gets smeared out. But with just 2 applicators and the dose distributions from having an incorrect connection, it will be huge. So this, I'm hoping it illustrates, just because it seems like an easy procedure, you have just 2 applicators, a tandem and ring, you really need to know your applicators, your procedure, be 100% confident in your planning, your treatment, your connections. All right, right on time. So conclusions. So GYN brachytherapy procedures, they've been used for decades. They're an effective treatment. We wouldn't be learning about them if they weren't effective. There are a variety of applicators available for use for GYN procedures, each with their own pros and cons that you'll need to think about and evaluate and determine what's best for your site and your patient population. Follow some standard loading patterns and rules. It allows for safe and effective treatment plans. Again, consistency is very important. If you don't follow consistent plans, it's another way of introducing possibility for error. It's important to think outside the box and use creativity when discussing treatment options. And when starting a program and upon program review, it's really important to look at your overall process, critically analyze the areas where failure modes are likely to arise, and then try to use safety barriers to mitigate those. So that concludes that. I do want to say a few last words here. So the talk, I believe everyone has access to this talk. My talk today and the one I will be doing on the ring, they also have in the notes section kind of subtitles or captions so that you can read along. If I went through quickly today to try to fit in the hour, you can always go back and look at that. Next week, Derek Brown is going to be presenting cylinders and tandem and ovoid applicators. And then the following week, I'm going to do tandem and ring. I'm going to talk with the group. I have a video that goes over tandem and ring planning. So I would like to get that distributed fairly soon so that everybody could take a look at that, because I don't actually have a lot of slides on the tandem and ring planning. A lot of it I would like you to see and be more interactive with questions and things like that. I'll go over a few things, but I really want you to see the video. It kind of gives you a qualitative overview of the planning process. And then one of the resources, we have posted videos on this on I Treat Safely, itreatsafely.org, and I'll see if the group can also get the videos distributed, but there's a cylinder treatment planning video. There's a tandem and ovoid video that also includes one of our physicians contouring and talking about the contours. And then, as I said, the tandem and ring, we'll get that distributed soon so people can take a look, hopefully before the lectures next week and the following week. Let's see. Another question. So do me and the team frequently debrief after procedures, say once a week or so? If so, what do you find most useful about the sessions? If not, why not? That's a great question. So we debrief quite a bit. So we do it in a variety of ways. So we have a very busy schedule. I think the most treatments we've done in a day is 10 or 12 in a single day. And so we debrief frequently during the day from nursing, from physicians, from physics, because we need to be very, very efficient to get that many patients pushed through our day. So we'll typically, huddle at various times during the day about procedures. Our big huddle, we do a weekly chart rounds, brachytherapy specific chart rounds. So all the physicians who are involved with brachytherapy, we'll get together and we'll talk about the best implants for those patients. We'll look at our EQD2 spreadsheets. So after they've had one implant, what it projects to, what we could do better if that patient, is going to need supplementation, if they need to go from an intracavitary implant to a hybrid or even to a full interstitial to make sure that we're hitting our organs at risk dose properly. So we have a few different times where we debrief, but overall we do it several times during the week, sometimes during the day, especially moving from patient to patient and how we're going to organize them. So hopefully that answers the question. Any other last questions? Again, we are a small community with brachytherapists, so always feel free to phone a friend, to reach out. We're all here to help. Any of us from the group have all mentioned, feel free to contact any of us with specific questions, even if they don't get answered here, and we'll try to help. We're happy to help. So I don't see any more questions, so I think that's it. We are going to wrap up. So thank you very much all for your attention, and we'll see you soon in the coming weeks.